You're going to use either the 2 to the focus gallbladder examination. Let's take a look first at the exam essentials. For a transducer, you're going to use either the 2 to 5 megahertz curvilinear or 2 to 5 megahertz phased array transducer. From a patient standpoint, you want them positioned initially in the supine position. However, if a stone is seen, you're going to have to do the exam in 2 positions in order to determine mobility of the stone, especially if the stone is down in the region of the gallbladder neck. From a patient preparation standpoint, ideally the patient should be NPO, but that's not realistic in the emergency department, and the exam should be performed regardless of prandial status in this symptomatic patient. The decision to begin the gallbladder exam in either the sagittal or transverse windows is purely an individual decision. The sagittal exam, however, is going to be begun by placing the transducer under the right costal margin with the indicator directed towards the patient's head. The transducer can initially be placed in approximately the mid-clavicular line, but since the location of the body of the gallbladder can vary, it's not uncommon to have to move the transducer from side to side and rotate the transducer gently in order to locate the gallbladder. But in most cases, I would recommend starting with the transducer in the mid-clavicular line, just under the costal margin on the right. Okay, let's take a look at the sagittal gallbladder exam, moving from the patient's right to the patient's left. So we're going to begin in this position and move over in this direction. So if we look at the exam from our starting point, you've got the transducer here, so it's anterior, posterior, head, foot. You can see that we're using the liver here as a window. You've got diaphragm here. This is pleural space up here. Here you have the kidney. The fact that you see the kidney on this sagittal view should lead you to, cause you to move the transducer in a more medial or leftward direction on the patient, since the gallbladder lies anterior and medial to the right kidney. But if we go ahead and start moving through, you can see we start sweeping through the liver. We start getting bile gas in here with its dirty shadowing. But we can start seeing now the anechoic gallbladder starting to fill in here. And you can see here, now we've got a nice sagittal view of the gallbladder. You've got the fundus and body up here. You've got the neck down in here, and it's really important that you visualize the neck, since this is where the stones are going to be that are causing obstruction. You can see here is the right portal vein. As we continue to move in a leftward direction, now you can start seeing at the very end the inferior vena cava. So we'll sweep through one more time. There's gallbladder, and as we sweep through more to the left, here you can see the inferior vena cava here in the sagittal plane. The main lobar fissure, which you can see here on this video, is a consistent landmark that goes from the gallbladder and connects over to the right portal vein. In challenging cases, this landmark can be used to locate the gallbladder and to verify the identity of the gallbladder. And you can see it, like I said, right here, extending from the gallbladder to the right portal. You can also see it down here on this still image, extending from the gallbladder to the right portal. So it's important to keep an eye out for this when you're scanning the gallbladder. What if you can't find the gallbladder? It's not uncommon that the gallbladder won't be visualized after initial transducer placement. If the initial view with the transducer placed under the right costal margin does not reveal visualization of the liver, then have the patient take in a deep breath, since this will flatten the diaphragm and bring the liver closer to the transducer. In this patient, the initial view provided only demonstrates dirty shadowing from bile gas, and you can see that all right here. You may see a little bit of the tip of the liver right here. However, now with inspiration, you can see that the liver and the gallbladder, here you've got the liver and the gallbladder, become clearly visualized. Another thing you could do is turn the patient into the left lateral decubitus position, since this can also be used to aid in gallbladder visualization. But remember, if all you're seeing is dirty shadowing, have the patient take in a deep breath. Okay, so what if you still can't find the gallbladder? You've had the patient take in a deep breath. You've turned the patient on their left side and you still cannot find the gallbladder. You have to ask yourself, what are you seeing? If all you're seeing is dirty shadowing from bowel gas, then you may have to scan the gallbladder from an intercostal approach. However, if you are seeing the liver but don't see the gallbladder, you have to ask yourself, is the gallbladder either congenitally or surgically absent? A lot of times patients forget to tell you they have their gallbladder out remotely. The gallbladder may be contracted, and that is not uncommon in the ED population who may have just eaten. And here you can see a gallbladder that is completely contracted. You've got the anterior wall, the posterior wall. Here's the very thin lumen. And what you can see here is the right portal, and here's the main lobar fissure. So we know that this is the gallbladder. The last thing that may create a diagnostic dilemma for you is a gallbladder that's filled with stones. So these are the potential causes for still not being able to find the gallbladder. The gallbladder can be absent congenitally, which is very rare. More commonly, the gallbladder is going to be absent as a result of cholecystectomy. Frequently, patients may not reveal this history, and the laparoscopy scars may be difficult to see, or the physician may just not have asked the question. In this patient with right upper quadrant pain, a focused gallbladder ultrasound was performed. You don't see the gallbladder at all. You've got, however, some echogenic foci with posterior shadowing right in this area here, and this is due to the presence of surgical clips. The CT scan that was ultimately performed on the patient demonstrates here surgical clips as well as surgical absence of the gallbladder. Okay, a patient who has recently eaten will have a contracted gallbladder due to the expulsion of bile. This will make visualization challenging. In the video on the right, the gallbladder is contracted, but there's still some bile seen within the gallbladder lumen. You can see here you've got the right portal, main lobar fissure, and here's gallbladder, so you know that this is a gallbladder you're visualizing here. On the left, however, it's going to be a little more challenging. You've got the right portal, you've got the main lobar fissure, and you can see that this is a completely contracted gallbladder. So you have to keep this in mind when scanning ED patients who may have just recently eaten. Lastly, let's take a look at a gallbladder filled with stones. As we start sweeping through the gallbladder here, you can see that right now we're sagittally going through the gallbladder. So you've got anterior, posterior, head, and foot. If you take a look here, you've got this shadowing, and that's the first thing that you recognize, and it appears to be a clean shadowing. This is all anechoic, as opposed to this area right up here, which is dirty shadowing due to bowel gas. So you've got this echogenic line here, followed by clean shadowing. This was a patient whose gallbladder was completely filled with large stones. And as we sweep through again, you can see the gallbladder here filled with stones and the thickened wall. So keep an eye out for the type of shadowing that you see. This may be the first thing that'll clue you in that you are indeed over the gallbladder and that it's just filled with large or multiple small stones. This concludes the sagittal portion of the gallbladder examination video. Now move on to the transverse portion of the gallbladder exam video. I'm Dr. Robert Jones, and in this lecture we're going to cover the transverse portion of the focused gallbladder examination. Let's go through the exam essentials one more time. The transducer you're going to use is going to be either the 2.5 megahertz curvilinear or the phased array transducer. Remember, the decision for what type of transducer to use should be based on how far you anticipate having to penetrate into the abdomen, since this is linked to the frequency. Higher the frequency, the less the penetration. So in the average adult, to scan the gallbladder, you're going to need within the 2 to 5 megahertz range. The decision to use the curvilinear versus a phased array is going to be based on your access to the various types of transducers as well as your preference. I would prefer to use a curvilinear if at all possible, but a phased array could also be used. From the patient positioned standpoint, again, start them off supine. However, if you see a stone, particularly down by the neck, you must scan them in 2 positions to verify the mobility of the stone. And from a patient preparation standpoint, ideally they should be MPO, but regardless of their prandial status, still scan the symptomatic patient. Remember, the decision to initiate the exam with the sagittal or the transverse window is purely an individual decision. To do the transverse exam, it's going to be initiated by placing the transducer in the transverse plane with the indicator directed towards the patient's right. You can see here the indicator is towards the patient's right side. So you can see from an image orientation standpoint, you've got the indicator here. So this is going to be anterior, posterior, patient's right, patient's left. You're using liver here as a window. You've got the anechoic gallbladder here, and you can see that the gallbladder is anterior and medial to the right kidney. So you can use this as a landmark when you do the transverse exam. Here is a transverse exam of the right upper quadrant, including the gallbladder. You can see here as we start, you've got anterior, posterior, patient's right, patient's left. Here's the liver. Notice here the dirty shadowing from bowel gas. As we start sweeping in a caudal direction through the gallbladder, you can see the anechoic gallbladder here. Now we're sweeping up towards the neck. Now we're sweeping down towards the fundus. Adjacent to it right over here on the patient's left is going to be some bowel gas. You don't want to confuse this as being a gallbladder filled with stones. Remember, if you have any doubt about what you're looking at, verify its location to the right portal vein. Here's another transverse exam of the gallbladder. Note here that you're able to scan the neck in the transverse plane, and it's an important area to look at since this is where stones are going to be in terms of obstruction. Again, you can see that the right kidney's here, so the gallbladder is going to be anterior and medial. You don't want to confuse the inferior vena cava as being the gallbladder on the transverse window. But notice here we've got the gallbladder neck, and then we can sweep through. We're going from the neck, coming down into the fundus. And so you can see the gallbladder transversely here. You can see the transverse width, which we'll talk about during the interpretation part. You can also see anteriorly a nice gallbladder wall that could be easily measured. As discussed in the sagittal exam video, there are multiple reasons why the gallbladder may not be visualized. If you're starting off with the transverse window, you're going to be asking yourself the same questions. Why can't I find the gallbladder? You've got to ask yourself first, what are you seeing? If you're seeing on the screen a lot of dirty shadowing and you're not able to see any of the liver, have the patient take in a deep breath or turn them on their left side. If that doesn't work, you may have to scan intercostally in order to find the gallbladder. However, like on this image here, you've got a transverse image. You are seeing the liver, but the question is, why are you not seeing the gallbladder, or why are you not recognizing the gallbladder? Again, it may be because the gallbladder is absent, either surgically or congenitally. The gallbladder may be contracted due to a recent meal, or the gallbladder may be filled with stones. In this case right here, you are seeing a transverse view of the gallbladder. You can see its wall right here. Here's its lumen, but this is a contracted gallbladder in a patient who has just recently eaten. Here we have a patient who has had their gallbladder out remotely. This is a patient with underlying liver disease as well as ascites. You can see on this transverse view here that within the gallbladder fossa there is no gallbladder, but you can see these echogenic foci with posterior shadowing. These are the surgical clips from their prior cholecystectomy. In this video on the right, which is a transverse view of the gallbladder, you can see the contracted gallbladder. There's still some bile present within the gallbladder lumen, but it is clearly contracted. This patient had just eaten a meal approximately 1 hour ago. In the image on the left, the gallbladder is completely contracted. There is very little of a lumen that can be visualized. For the novice scanner, the more contracted the gallbladder, the more difficult it's going to be to visualize. In these cases, you really have to look for the main lobar fissure so that you can, verify that the structure you're looking at is indeed the gallbladder. In this video on the right, which is a transverse view of the gallbladder, you can see the contracted gallbladder. There's still some bile present within the gallbladder lumen, but it is clearly contracted. This patient had just eaten a meal approximately 1 hour ago. In the image on the left, the gallbladder is completely contracted. There is very little of a lumen that can be visualized. For the novice scanner, the more contracted the gallbladder, the more difficult it's going to be to visualize. In these cases, you really have to look for the main lobar fissure so that you can, verify that the structure you're looking at is indeed the gallbladder. This concludes the transverse portion of the focused gallbladder exam video.